আপনারা যারা ঢাকার বাইরে থাকেন অথবা যারা রিসেন্ট ট্রেনি, তারা আসলে স্যারের ক্লাস বা স্যারকে ভাবে পাননি, এটা আপনাদের জন্য একটা খুবই বড় একটা সুযোগ এবং খুবই বড় একটা অপরচুনিটি যে আমরা আজকে দীন মোহাম্মদ স্যারের ক্লাসটা মেডেক্সেল এর মাধ্যমে আমরা অ্যারেঞ্জ করতে পেরেছি। আমি স্যারকে আমাদের তরফ থেকে এবং খান আবুল কালাম আজাদ স্যারের তরফ থেকে ধন্যবাদ জানাতে চাই। স্যারকে পরিচয় করিয়ে দেওয়ার কিছু নেই। স্যার যেমন ন্যাশনাল ইনস্টিটিউট অফ নিউরোসায়েন্স এন্ড হসপিটালের ডিরেক্টর থেকে স্যারের বড় পরিচয় হতে স্যার আমাদের সবার গার্জিয়ান। বিসিপিএস এর প্রেসিডেন্ট, বাংলাদেশের পোস্ট গ্রাজুয়েশন যে শিক্ষার যে এখন যে অবস্থা আমরা এসেছি তার পেছনে স্যারের অনেক বড় অবদান। আমি আর সময় ক্ষেপণ না করে আমি স্যারকে অনুরোধ করব, স্যার ঠিক যেভাবে হয়তো পুরোপুরি হবে হয় না, কিন্তু যেভাবে স্যার ঢাকা মেডিকেলে ক্লাস নিতেন ট্রেনিংদের এফসিএস কোর্সের স্টুডেন্টদের, ঠিক সেভাবেই স্যার আজকে একটি ক্লাস আমাদের জন্য নেবেন। এবং খুবই ইম্পর্টেন্ট, যেটা নিয়ে আমাদের সবসময় সবার খুব কনফিউশন থাকে, সিএনএস সিম্পটম অ্যানালাইসিস, সেটার উপরেই আজকে স্যার ক্লাসটি নেবেন। স্যার আমি আপনাকে ক্লাসটি শুরু করার জন্য অনুরোধ করছি। থ্যাংক ইউ।
Yes. Thank you very much. First of all, I am again very well thankful to the Medixel for inviting me to deliver a lecture on CNS symptomatology. If I remember, I think a couple of months back, maybe more than that, I had a similar talk. At the time, the talk was mostly on peripheral symptomatology based on peripheral nervous system and spinal cord diseases. So today I naturally and obviously try to concentrate my talk on symptomatology on brain symptoms or brain diseases. Because if I go beyond the brain, there could be something, duplications or recapitulations. So I will basically will be concise to the symptomatology related to brain disorders. And obviously, if you consider or deliver any lectures, any talk on nervous system, you must know the neuroanatomy, neurophysiology in details and in good. Because any symptomatology in neurology basically is related to the underlying organ mostly. And in the other way true, that symptomatology means impairment of normal function or dysfunctions. And the dysfunction of some part of the brain or the organ give rise to symptomatology. So dysfunction give rise to symptomatology. So you must know what is the function. So from the function to dysfunctions, then to symptomatology. That is in one sense straight chronologically related to the presentation or symptomatology of any diseases. Keeping this thing in mind, I have tried to describe my lecture as usually starting from the brain first. We all know the nervous system consists of the brain, spinal cord, and peripheral nervous system. And in the brain, we know that there are different lobes, which we call the frontal lobe, and the frontal lobe, then we call the parietal lobe, then we call the occipital lobe, and temporal lobe. Besides, there is diencephalon, brainstem, and cerebellum. In the diencephalon, consists of basal ganglia and thalamus, and the brainstem consists of midbrain, pons, and medulla oblongata, and cerebellum is an independent organ lying below the whole aspects of the brain, connected in front with the brainstem. And the medulla oblongata is otherwise called the bulb. It is also called the bulb. So, if you see, the next one, the spinal cord, it has got three parts, cervical, thoracic, lumbar, and peripheral nerves, cranial, spinal, and there are another division of nervous system which is called the autonomic nervous system. Here you see that the different lobes at a glance. This is called frontal lobe, this is called parietal lobe, occipital lobe, cerebellum, and the temporal lobe. You also know that the lower concept of the brain is not only based on anatomical landmark or anatomical border, it is also based on the difference in functions and difference in blood supply. We know that frontal lobe has got different source of blood and different functions. Similarly, parietal lobe, occipital lobe, temporal lobe, and cerebellum, and also brainstem. So, anatomically different blood supply, anatomically different border zones, different divided by the different sulci and zygons, and functionally also there are major differences in functions. If you consider the brain as a whole, that functionally you call dominant hemisphere and non-dominant hemisphere. In a right-handed person, left hemisphere is always dominant. In a left-handed person, left hemisphere is also dominant, about 80 to 90% cases. So, left hemisphere is usually called dominant lobe and right hemisphere is called non-dominant lobe. This difference in dominance has been based on difference in functions, particularly the two functions. One, the language. The language function is present in the left side, not in right side. One, and the fine architectural function is based on left side, not the right side. This is the fundamental difference between the dominant and non-dominant. And in the non-dominant, there are other functions which are more prominent. As for example, the coordinated work like apraxias, agnosias, two-point discriminations, these are all predominant in the non-dominant hemisphere, right hemisphere. So this is very important because if you see from my discussion that if a patient presents with problem in speech, particularly dysphasia or aphasia, you can consider the lesion must be in the dominant hemisphere. I repeat, if a patient presents with dysphasia, the lesion must be in the dominant, fundamental difference. But if a patient presents hemiplegia, lesion could be the right side, could be the left side. Right side, left. So, you should know the function of the different parts of the brain. Here I know that I am coming back to my topic. That you see that this in this slide, in frontal lobe, parietal lobe, and in the temporal lobe. And you know the functions of frontal lobe. What are the functions of frontal lobe? If you consider and just see the picture in front of your eyes, why is the frontal lobe? It lies in front of the central sulcus. In front central. So, what are the parts there? In front of central sulcus, you will see motor area 44, 45. Therefore, then in front of that premotor area and in front of that there is other association areas. So in the frontal lobe, there are many areas, but functions are very limited. The main function of frontal lobe is voluntary motor movement. That means movement of one opposite side of the body. Opposite side of the body is controlled by the placental gyrus. motor speech area, that's the Broca's area, which is called area 44 and 45, also lies in the frontal lobe. Then executive for higher intellectual functions like cognition, behavior, personality, social sense, all lies in the frontal lobe. So you see that if I go back to symptomatology, if a patient presents with speech problem, motor speech problem, you know that speech is dysphagia, another is dysarthria. The dysphagia and dysarthria, to discuss and differentiate, needs one class, 1 hour, 1.5 hour topic. So this is totally two distinct, different things, dysphagia and dysarthria. One should not confuse with dysphagia and dysarthria, which is a different issue. So when there is speech problem, particularly motor, problem in expressions, motor dysphagia, along with that, there is hemiplegia, there is impairment of higher intellectual functions, like patient has loss of memory, personality loss of social sense and behavior. When a person has got this symptomatology, we can think about that this person might have a opposite frontal lobe problem, frontal lobe dysfunction. This is simple considerations, but maybe a little bit different. But fundamentally and basically, mostly, this relates to the frontal lobe function of the opposite side. So any lesion in the frontal lobe might cause either hemiplegia along with speech problem and other higher impairment of higher intellectual functions. This is very important. Coming to parietal lobe, similarly, the parietal lobe function is somatosensory area 3 to 1, and along with that, there is a speech center which is called sensory speech center or called receptive center. What happened then? If I ask your name, what is your name? You will tell my name is Azad. So I have asked the question to you, what is your name? What happened then? You heard what I asked. That hearing, it goes to the auditory nerve. From the auditory nerve, it goes to the auditory ganglia. From there, it goes to the auditory center, area 41 and 42, near the temporal lobe. So what I ask you, what is your name? Through the auditory nerve, it goes to the auditory center, primary auditory center. From where it goes to the sensory reception speech center, which is otherwise called Wernicke center. Otherwise called Wernicke center. So from the primary auditory center, it goes to Wernicke center. Then Wernicke center is comprehended. What I have asked, that is processed in the Wernicke center. From there, it goes to the motor speech area in the frontal lobe. From where you answer my question, my name is Azad. So this is a complex procedure, but this happens fraction of a second. This is a different class. For the student to differentiate dysphagia, dysarthria. Okay. So this receptive center or speech center or sensory center or Wernicke center lies in the parietal lobe, in the dominant side. So what happened? In the dominant side, there is speech center and sensory perception center. In the non-dominant, what happens? There is no speech center, but there is sensory center, and in addition, there is apraxia and agnosia. Perceptions of complicated things are in the non-dominant side. So when a patient presents with receptive dysphagia, What does that mean? I have asked the question, what is your name? He replied, I am fine. I am fine. So what happened? The answer was not relevant to my question. The answer was defective, not appropriate. That is called sensory speech problem. So if a patient presents with sensory impairment along with sensory speech problem, the lesion lies in dominant parietal lobe. On the other hand, if a patient presents with sensory symptoms along with apraxia and agnosia, then it is in the non-dominant lobe, right-sided. Remember, along with this, there could be paralysis of a hand on one side, but this paralysis is not dense like the frontal lobe. Is not dense like the frontal lobe. Coming to temporal lobe, where there is language comprehensions, hearing, emotion, and recent memory. Actually, temporal lobe is a very big, very important part of the brain, where many things are really controlled. As for example, part of the language, and most important is the memory, recent memory, emotion, and these three things are very important. So, and when the patient presents with memory impairment, language dysfunctions, along with that, if there is temporal lobe epilepsy, which is previously called psychomotor epilepsy, and now it is called complex partial seizure, that is indicative of temporal lobe dysfunction. In the temporal lobe, maybe lesions could be silent, symptomatology may be non-apparent for a long time, but the predominant symptomatology is complex partial seizure or psychomotor epilepsy. Along with that, there could be recent memory impairment. Keeping aside the all frontal lobe intact, the parietal lobe intact, only there could be temporal lesions. Remember, the frontal, parietal, and temporal, these global lesions could happen isolatedly, could happen together. Isolated lesion in these lobes mostly of two causes. One, the intracranial space occupying lesion, and two is the stroke. But these lobes can involve altogether. There are also 2-3 causes of altogether. 4 causes. 1, infection like encephalitis. 2, trauma. 3, toxic. And 4, metabolic. So, infection, toxic, metabolic, and hypoxic, like cardiac arrest, like respiratory arrest, in all 4 these causes usually involve all lobe of the brain. So whenever a patient presents with global symptomatology, all part of the brain involvement, consider 4 causes: infection, toxin, metabolic, and hypoxic. These 4 causes. Now for the occipital lobe, as you know, there is visual processing center. So when there is impairment of vision, in lesion to the occipital lobe, that gives the cortical blindness, Anton syndrome, and Valid syndrome. These are the classical presentations of cortical, but this happens when there is bilateral cortical infarct. Bilateral occipital cortical infarct gives rise to these. But when there is unilateral involvement, this does not give rise to the blindness. They give rise to the hemianopia. Opposite side, 1/2 of the vision is lost in the opposite side of the eye, opposite eye. Thalamus, which is usually called the pacemaker of the brain. The pacemaker because the state of arousal is usually from the thalamic stimulation to the cerebral cortex, and from the thalamus, the thalamus is the receptive center for all sensory modulation coming from different parts of the body, except the first, the anosmia or the smell sense. Anyway, but other sense coming from the body, any part of the body, even from internal organ, they first go to the thalamus. From there, the third order neuron goes to the postcentral gyrus through the ascending thalamic radiations. So thalamus continuously stimulates the cortex, and that is why it acts like a pacemaker in the heart. And thalamus is pure sensory organ, and lesion thalamus will give rise to pure sensory deficit on the opposite side. So if a patient presents with sensory dysfunction of the opposite side, keeping the motor functions intact, then the lesion could be the thalamus. But practically what we see in any thalamic lesions, there is not only sensory deficit opposite side, but there is also motor deficit. The patient presents with congenital hemiplegia and sensory loss. As thalamus is a pure sensory organ, why there is motor loss? Because the internal capsule lies between the thalamus and the caudate nucleus basal ganglia. So any thalamic lesion involves the internal capsule, and that is why they practically present as hemiplegia with other sensory deficit. Basal ganglia, the organ that tune the motor functions. Its main function is to refine, is to tune the motor functions, coming from the cerebellum, coming from the frontal lobe, wherever the motor function arises, when it is executed, it is refined by the basal ganglia. যেমন আমরা দেখি না, what we see, যে আমাদের যখন মডারেটর মডারেট করে, অনেক কোশ্চেন মডারেট করে, তারা কোশ্চেন সেট আপ করে, ঠিক তারা basal ganglia, they also moderate the motor functions. And when there is dysfunction of basal ganglia, so there is no tuning or finding of the motor movement. The motor movement, when its body was coarse and rough, that is presented in the body, in the opposite side. So there is resting tremor, involuntary movement, like Parkinson's disease, and rigidity. So when you find the tremor in the hands, but to resting tremor, involuntary movement, like chorea, athetosis, balismus, and features of Parkinson's disease or increased rigidity, that immediately you consider that these are the features of thalamic basal ganglia function. So dysfunction of basal ganglia will produce this kind of features. This is the reality that you should feel in one sense, that from the symptomatology, how can you go to the organ, and from the organ, what are the diseases that can produce this one. Cerebellum is an interesting organ, lying outside the whole brain chain, but it controls the brain. Its main function is to coordinate and maintenance of equilibrium. The function that we do in different aspects, joints, movements, different segment of a single function, and the equilibrium is maintained by cerebellum. You know that cerebellum has got primary lobe and secondary lobe, again divided median, paramedian, and lateral. Median, paramedian, lateral. If you recollect, the function of cerebellum, you should know this function of cerebellum, you should know the function of cerebellum. The main two function is maintenance of coordination and maintenance of equilibrium. So what happened? When there is dysfunction of cerebellum, there will be incoordination and there will be disequilibrium. These two. So function is coordination and maintenance equilibrium. So dysfunction will be coordination means there will be incoordination. Equilibrium means there will be disequilibrium. These two. Interestingly, that these two functions of the cerebellum is limited to the part of the cerebellum. What happens? Lateral part of cerebellum maintains the coordination and medial part of cerebellum maintains the equilibrium. You see? So, when there is incoordination, the lesion lies laterally. When there is disequilibrium, lesion lies medially. Fantastic. But this is the difference. And how do the incoordination presents? How do the disequilibrium presents? The incoordination presents in the form of incoordination in the head nodding, incoordination in the eye, nystagmus, incoordination in the speech, scanning speech, incoordination of the finger, the hand movement, finger nose test, and incoordination of the limb is heel knee test. Coming to equilibrium, that what is the disequilibrium? It means ataxia. It means ataxia. There could be truncal ataxia, flocculonodal lobe or median or midline lesion, and there could be limb ataxia, ataxic gait or disequilibrium. So this is really very interesting. And sometimes there is a question asked by the teacher or given in the written that how can you differentiate, how can you predict or find the site of lesion by examining the cerebellar feature. I repeat, that's an interesting question. How can you find the site of lesion by examining the cerebellar features? Then two things you justify. One is incoordination, one is disequilibrium. So as I just mentioned, what are the incoordinations? What are disequilibriums? Remember, there are many features of cerebellar lesion, but the most important feature, only one feature that is diagnostic is intention tremor, not the others. Intention tremor is the diagnostic hallmark of cerebellar lesions. Then coming to midbrain, that in the midbrain, there are cranial nerve nuclei, ascending and descending tracts. And in the midbrain, the cranial nerve is third, fourth cranial nerve, ascending and descending tracts. But most important structure is the reticular activating system, which is a neuronal network. In the nets, there are a few centers, which are the most vital centers in the brain stem, like cardiac centers. So, reticular activating system is also very important and extends from the midbrain to the pons. And in the midbrain, as you know, third and fourth cranial nerve, ascending and descending tract. Remember, I repeat, in the midbrain, in the pons, in the medulla, every structure is so organized, so differentiated, that if you know the anatomy, you can clearly say where is the lesion. As for example, just keep the picture in front of your eye, the midbrain. What I told you, cranial nerves, descending and ascending tracts. In the descending tract, most important is corticospinal tract. Okay? In the ascending tract, most important is the spinocerebellar tract and medial lemniscus, that is spinothalamic tract. So in the midbrain, whole structure divided into two parts, medial part and lateral part. I repeat, medial part and lateral part. In the midbrain, pons and medulla, four structures lie medially. What? Third cranial nerve, fourth cranial nerve, medial lemniscus and corticospinal tract and medial longicular fasciculus. These structures lie medially. Third and fourth cranial nerve, corticospinal tract, medial lemniscus and medial longicular fasciculus. These lie medially, and everything others lies laterally. So when there is lateral lesion of the brain stem, pons, medulla, and medulla oblongata, there will be no paralysis because corticospinal tract is spared. Because it lies medially. When lesion lies medially, all four structures are involved. Cranial nerve, then the corticospinal tract, medial lemniscus, and medial longitudinal fasciculus. It's quite interesting. In the pons, similarly, we have got 5th, 6th, 7th, 8th cranial nerve, of which the 6th is motor, and 5, 7, 8 is the sensory and mixed cranial nerve. Similarly, medially there is some other things like medial lemniscus, medial fasciculus, and this. In the medulla oblongata, we have got the lower cranial nerves, 9, 10, 11, 12. And here, the 12th cranial is absolutely motor, that lies medially. Other cranial nerves laterally. So, whenever you consider the lesion in this area, what you can see? You can see that in the brain stem, I will come a little later then. Yes, this is sorry. Yes, I think. Yeah, I'll go in that part later. So, if I go back to the original one, that I'm sorry, these slides have been really, I did not follow this morning. These slides really ups and down. So I correct this one. So in the central nervous system, I go back to the brain. So what is the function of brain? That is higher intellectual functions, the consciousness, speech, sleep, and convulsions. These are in general the functions of the brain. And when there is convulsion, that indicates cerebral cortical lesion. I repeat, convulsion indicates cerebral cortical lesion. Unless the cortex is involved, there cannot be any convulsion. Lesion could be the cerebellum. Lesion could be diencephalon. But that should ultimately involve the cortex. And then it will produce convulsion. So convulsion indicates cerebral cortical lesions. Causes may be many. That depends on the either focal or there are convulsions. And impairment of higher intellectual function, as I told just before in the back slide, indicate, as I mentioned, that 4 causes are involved: hypoxia, toxic metabolic, then hypoxic, and infective. There is memory loss. In the brain, if a patient presents with memory loss, there could be 2 types of memory loss. One is amnesia, one is dementia. What is the difference? Amnesia means only memory component is involved. no other involvement of the other cognitive functions, only memory loss. This is called amnesia. And dementia means memory impairment along with impairment of other cognitive functions. That is to an extent that impairs the activity of daily living. So difference between amnesia and dementia is only segmental. Only segmental. Dementia, impairment of cognitive function, and in the cognition, memory, intelligence, judgment, activity slips. But amnesia, only memory loss. Only memory loss. Now coming to the most important part of presentation is unconsciousness or coma, which is a very crucial problem for the physicians and for the neurosurgeons. If you try to know the neuroanatomy of unconsciousness, it is very simple. A person will never be unconscious until and unless the reticular activity system is involved. Very clear. And reticular activity system lies in the midbrain and pons. So to become unconscious, that RAS should be involved. Interestingly, when there is unilateral reticular activity system involved, that produces semicoma. When there is bilateral, that produces coma. That produces coma. So when a patient presents with unconscious state, even to consider there is involvement of reticular activity system, patient could be in some other part of the brain, the frontal lobe stroke or parietal lobe stroke, temporal stroke, but that is just so large that has pushed the brain stem laterally, or somehow because of raised intracranial pressure, brain stem reticular active system has been involved. So for unconsciousness, the RAS should be involved. And remember, unconscious is not a disease, it's the expression of the underlying disease. That disease could be organic, non-organic, structural, non-structural. So, if a patient is unconscious, that makes two things. He is not awake and not aware. Not awake and not aware. That is unconsciousness. But a patient is awake but unaware. That is called vegetative state. That is called vegetative state. Awake but unaware. That is called vegetative state. Then how do you actually approach to a patient of unconsciousness? Approach is time consuming, but very, very important. Very, very important. First of all, at a glance, you see, if you consider the common cause of unconsciousness, it's usually road traffic accident, stroke, encephalitis, malignancies, poisoning, hepatic and renal failure, coma, diabetic or metabolic coma, CPD, hypertension, and convulsion. There are many causes, medical and surgical causes. But always keep road traffic accident in your mind. Then the patient, when you examine, then you see the scale of the coma through the Glasgow coma scale. Then if you see any external injury mark, then you look the people. People examination is mandatory. If the people is pinpoint, then consider either pontine lesion or poisoning, morphine poisoning. If the people is asymmetrical, one is large, one is small, consider intracranial space occupying lesion or traumatic brain injury, like ixon, like stroke, or traumatic brain injury. If the people both are big and large in size but reactive, consider diencephalic lesions. Then, after the people, you go to the eyeball. Look at the eyeball. What is the position of the eyeball? If the eyeball normally looks like normal, or any change in the eyeball. The horizontal deviations or consecutive deviation of the eyeball to the one side. Say for both the eyeball is directed towards the right. When you look at the eyeball looks towards the right. Then what that indicate? That indicate lesion could be in the right side of the brain or could be the left side of the brain stem. So, division of eyeball towards the right indicate ipsilateral brain lesion or contralateral brain stem lesion. Contralateral brain stem lesion. If the eyeball is mid position, no deviation, it is probably because of diencephalic lesions. If the eyeball looks down, the lesion is virtually upper mid-brain lesions. If the eyeball has got skew deviation, one down, one up, either brain stem or cerebellar lesion or brain lesion. And so after the people, you should look in the eyeball. And if the eyeball has got continuous horizontal movement, eye rolling, that indicate epilepsy. A patient has got subclinical seizure, which is very, very important in ICU setup. You see the eyeball, normal. The upper one is normal eyeball, looking both equal. The next one pupil is dilated and one pupil is small. That indicates intercranial space occupying lesions. Then you go to the fundoscopic examination, weak swelling, acute hydrocephalus, or increased intercranial space occupying lesion. Before all this, you see the breathing pattern of the patient, because this breathing pattern may have an definitive diagnostic value, because that this kind of Kussmaul respiration, chain stroke respiration, period speeding, apnostic breathing, these are all features of brain stem lesions, and wide speed is features of meningitis, apnostic is features of pontal lesions. Then Kussmaul's metabolic coma, metabolic acidosis, there could be a Kussmaul breathing. Respiration gradually gets deeper and deeper, then arrest, then it goes up. So if you look at the different patterns of respirations, there could be a very good guide for the unconscious patients. Then this problem that I also mentioned earlier, that this could be either dysphagia or dysarthria. Dysphagia indicate cortical dysfunction, and dysarthria could be due to many other causes, maybe in the cortex, and maybe below the cortex. And then you look for focal neurological deficit. When a patient has got hemiplegia or monoplegia, present with hemiplegia, the monoplasia, the one thing, the lesion in the opposite side. The lesion in the opposite side. When a patient presents with cranial nerve palsy, the lesion may be the brain stem, mid-brain, pons, and medulla oblongata. Depends on which cranial nerve is involved. As I mentioned earlier, the third, fourth is midbrain. 5th, 6th, 7th, 8th is pons. 9th, 10th, 11th, 12th is medulla oblongata. So depending on cranial nerves, you can find out the site of lesion. When there is bilateral sixth nerve palsy in a patient unconscious state, that indicates raised ICP. When there is unilateral sixth nerve palsy, That could be due to either trauma or stroke or nasopharyngeal carcinoma. One of the important things that always keep in mind the posturing of the patient, that is decorticate and decerebrate. Decorticate posture and decerebrate. In the top, you see the decorticate. That means the hands are flexed and legs are extended. This is called decorticate. And down when you see the decerebrate, you can see the clear picture that what does it actually mean. And in the decerebrate and decorticate, this indicates the brainstem involvement. That means decorticate, the cortex has been disconnected from the lower center. And decerebrate, midbrain has been disconnected from the spinal cord. So these two are of great prognostic criteria if you see in an unconscious patient. If you see them, and this happens mostly in traumatic brain injury or in an intercapsular condition, giving rise to raised ICP. So as a whole, you must look into the patient very clearly and carefully so that you can see. Then I go back after the brain, we go to the brain stem, the midbrain, the pons and medulla, and in the midbrain, then you can see hemiplegia. I told you, yes. Now I would like to answer one of the important things. When there is hemiplegia, that means hand and leg is involved. Normally, in hemiplegia, there is involvement of one half of the body. That means the face, the hand, and the leg. But if you see hemiplegia without facial involvement, face is normal, please consider the cause in the cervical cord. Please consider cord in the cervical cord, because in the brain lesion or capsular lesion, it is expected to see also the facial drooping. When there is equal involvement of the hand and the leg, including the face, the lesion lies in the internal capsule. When the leg is more involved than the hand, that gives rise to parasagittal lesion. That is paracentral lobe. When the hand is more than the leg, that gives to precentral gyral lesion in the lower part. So, equal involvement in one side, capsular lesion. Leg is more than the hand, paracentral lobule, upper part of precentral gyrus. Hand is more than the leg, lower part of the precentral gyrus. You see the homunculus here. Here you see, this is the precentral gyrus. And here is the face area, and here the leg area. You see the leg area. So when the leg is more than the hand, lesion lies here. When the hand is more than leg, lesion lies here. That's clear difference. There are other things that can happen along with this one. So I now come to the another aspects of the brain symptomatology, which is called headache. Headache is not a disease. It's a symptom of the underlying disease. And in neurology, we see hundreds of cases of headache regularly. But what are the headaches that demand special attention? That is sudden severe headache and headache of acute acute onset headache. When there's sudden severe headache, along with vomiting and obturations, sudden severe headache, vomiting and obturation, the diagnosis is subarachnoid hemorrhage unless proved otherwise. So, besides the subarachnoid, the headache could be due to first attack of migraine and following head injury, acute hydrocephalus, tracts and meningitis. These are the other causes of acute headache. And headache is a different chapter, that we may discuss in future in our separate class. Now, I come to the brain stem syndromes that sometimes we see, and immediately we can diagnose by looking into the patients. As I mentioned, that the brain stem consists of midbrain, pons, and medulla oblongata. So how can we diagnose brain stem syndrome? Coming to the midbrain, as I have mentioned, that in the midbrain there is cranial nerve third and fourth. Okay? So when a patient presents with third or fourth or both cranial nerve palsy, if there is no long track sign, I repeat, when the third or fourth or both cranial nerve palsy, if there is no long track sign, the lesion lies in the periphery, outside the brain. But when there is associated long track sign, the lesion lies in the brain stem. Why is that? If third and fourth involved, in the midbrain. So, in the midbrain, there are few syndromes, classical syndromes, which are called Weber syndrome, Claudy syndrome, Benedict syndrome, North-Nagal syndrome, and Perinaud syndrome. These are the syndromes where the cranial involvement and contralateral, either cerebellar or corticospinal tract deficit. You can see these things in the books, but one thing important, whether the lesion lies brain or outside the brain, that depends on deficit of or impairment of long tract functions. Then coming to the pons, there are two syndromes. One is Miller-Gabler-Raymond syndrome. In the pons, I have now told you that there is 5th, 6th, 7th, and 8th cranial nerves involvement. Usually 6th and 7th involved. Along with that, there is contralateral hemiplegia. So, pontine lesions give rise to ipsilateral cranial nerve nuclei, palsy, and contralateral hemiplegia. This is also true for all kind of brain stem syndrome. Again, the same principle here lies, whether the long tract involved or not. Then medulla oblongata. For quite often, we see patients of medulla oblongata or bulbar involvement. Other name of medulla is the bulb. Here there is Ebley syndrome, Jackson's Wallenberg syndrome. Wallenberg syndrome is very important. All the time, what we see and is popularly known as lateral medullary syndrome, lateral medullary syndrome. Here there is ipsilateral, 9th, 10th, 11th nerve palsy and contralateral spinothalamic tract or sensory deficit. Along with that, there is also Horner syndrome because of descending sympathetic tract involvement. So the patient presents with difficulty in swallowing, acute onset of difficulty in swallowing. If we examine the patient, you can see there is ipsilateral Horner and palatal palsy. If you carefully examine, you can find contralateral sensory deficit. This is very classical presentation of lateral ventricular syndrome, which we see quite often. Yes. Coming to the cerebellum, you see the cerebellum is two lobe organ, one unilateral and bilateral, one side and both sides. When the lesion lies in one side, unilateral cerebellar lesions, as in stroke, that due to acute stroke, trauma, abscess. When the unilateral cerebellar features are of sudden onset, consider three things: unilateral, sudden onset, unilateral cerebellar features. Three things: stroke, trauma, abscess. And chronic unilateral cerebellar lesions, consider two things: one, space occupying lesion, and two, a cerebellar agenesis or vascular malformation. If the bilateral cerebellar features or global cerebellar features, if it is an acute onset bilateral cerebellar feature, consider encephalitis, trauma, and toxic. Toxic, encephalitic, and trauma. If it is bilateral chronic cerebellar lesions, consider degenerative, hypertensive, and hypothyroidism. Degenerative, toxic, and hypothyroidism. These causes, usually common causes of bilateral cerebellar lesions of chronic onset. So, I think I have tried to cover almost our brain, and I will not cover the spinal cord today because of I have discussed the spinal cord in my last class, and now if I really summarize the class, this is spinal cord picture. I have discussed this in my last class, and this is the same thing discussed. So, look, in nutshell, in summary, the symptomatology arising from the brain, how can you recognize and how can you correlate these symptoms to an organ, and in the organ, what are the diseases that you can see? So coming to this, all these three, as I mentioned earlier, that you must know the anatomy perfectly. What is the function of different parts of the brain? So there are common features of brain dysfunction presentation, like impairment of higher intellectual function, then impairment of the thalamic function, diaphragmatic function, and brainstem function, of which the important issues are high brain function, intellectual function, that level of consciousness, intelligence, orientation, memory, speech, sleep, and either monoplegia or hemiplegia. These are all involuntary movements. These are all features of global brain involvement. In the brain stem, the respective cranial palsy and long tract deficit, maybe motor, maybe sensory. So when we examine the patient, try to find out what are the deficits he has. If a patient unconscious, then first you should have external observations like the breathing pattern, how the breathing pattern of the patient, position of the patient, cerebral decorticate, external injury mark. Then you go to the people. In the people, there could be a structural lesion and there could be non-structural lesions that can involve the people. Remember, If a patient is unconscious and the people is normal, I repeat, if a patient is unconscious and the people is normal, most probably it's metabolic. Most probably it's metabolic. When there is involvement of people, maybe asymmetrical, maybe in size, it indicates structural lesions. I repeat, it indicates structural lesions. So after the people look at the eyeball, then they look for any focal paralysis, hemiplegia or monoplegia, then the positions, then you examine the reflexes, plantar response, unilateral extensor is a focal lesion, bilateral extensor, maybe focal, maybe global, maybe focal, maybe global. This is how we analyze an unconscious patient. Then you go for speech analysis, as I mentioned. Then you go for the other intellectual functions, memory. Then you go for cardiac involvement, and the focal paralysis. This is, in reality, in short, that symptomatology to diagnosis in the brain. So I think I have tried to cover in short all aspects of the brain symptomatology. Then if you have any questions or query, you can ask me. Thank you. Thank you, Mr. All my participants for your kind attention.
থ্যাংক ইউ স্যার। আপনাদের যাদের কোয়েশ্চেন আছে আপনারা হ্যান্ড রেজ করতে পারেন, চাইলে আমি আনমিউট করে আপনাদেরকে কথা বলার সুযোগ করে দেবো।